Thank you. Dr. Sara and I met a couple of weeks ago to go over this, and I want to share this as an opening because it's so telling of who Dr. Sara is. But he made me an espresso in his home, and he said, "John, we're presenting at 4 o'clock on the second day of the symposium. Let's make this conversational and relax and talk about the work that we do." And I couldn't have agreed with him more, and so I went back to the drawing board, and here is what we're going to do. We're going to present really the work with integrative treatment and what that means entirely, covering these points. Traumatization of cancer diagnosis, medical treatment, trajectory and impact of that, integrative treatment planning from a family-centered perspective, and then music therapy and pain. And we're just briefly going to look at body, mind, spirit integration, and then end with a little bit of cap on environmental music. So these are the areas that we're covering. And I'm going to start out by turning it over to Dr. Sara to talk about what it means to diagnose a patient with cancer.
Well, first of all, thank you very much for inviting me. I'm happy to be here, and I want to congratulate you that you are still awake after 2 days of intense course in music therapy and pain. So it's really wonderful to be here and share with you some of our experiences. As an oncologist, I will tell you, when patients come to me for the first time, they are really deeply wounded. I would say not even wounded, they are destroyed. My feeling is that when you see this patient coming the first day to you, healthy, 45, 50, whatever their age are, and they were just told they had cancer. Many times cancer presents without symptoms. An X-ray or a test will show the cancer. So these people are feeling fine, and suddenly the world turned around completely. Everything turned around for them. I compare it to a woman who's been raped but didn't know about it. And the next day she's informed that she was raped and she's pregnant on top. So it's much harder to get to a closure when you didn't see it happening to you. I'm sure that it's hard for anybody to be raped, but you can get some closure when you remember what happened, you see the guy who did it, you can find some peace. But when you don't know and you are informed, by the way, it happened to you. It's just horrible. I see these patients sitting in front of me totally destroyed, dismantled. They could be a powerful husband and CEO and a wonderful woman, and they're nothing now in front of you. You just feel like you need to rebuild them back. So beside, of course, the chemo and the surgery and the radiation, which are things we should master, there is this whole piece of these patients that we need to put together. We cannot just put them back and have them go and fight and all that unless we take care of their soul and help them feel better. So that's where, all this work is really coming into play. And beside sitting, talking, which is very important, of course, and trying to make them realize that they are alive. They're not destroyed. They still can drive their car. They still can hug their family. They can still function. There's a lot of things that we can do to help them. And the music therapy has been just amazing into this experience at the hospital. So this is at least what I would tell you, how we feel about this trauma. We talk about pain, of course. As I said to you, a number of patients will have no pain, but the mental, the moral, the soul pain is horrible. Painkillers don't work for it at all. So that's the pain that we need to remember that is part of the physical pain, and we just can never and should never ignore it.
And I think that, the fact that you're referencing the trauma of a rape is interesting because anyone who works in medicine knows that new diagnosis often has the same impact as a traumatic event. And so the processing of news, of diagnosis, happens in phases and differently for every person. And so I actually like how this is broken down here in terms of survival strategies that are often activated, and we can see these manifest in a variety of ways. Certainly rescue and attachment are themes that are activated in terms of not only the patient in trying to hold on to themselves in the midst of diagnosis, but also caregivers. Assertiveness, goal attachment versus adaptation, goal surrender. I like this too because I think it's talking about the initial response to cling to what's tried, what we know, that feels safe. It's grounded, and it's often the most secure place for a patient to go to, as opposed to understanding treatment through the dialogues that are well intended and well informed with the physician, can reach a point of adaptation, to let go of some of that rigidity that feels safe in the beginning, to then work collaboratively and integratively with the physician. And this all mirrors the fight or flight equal response that Dory had talked about earlier. And again, looking at competition as a fight, or cooperation as not so much flight, but the opposite of fight in this case. So type in here too, but I look at the needs. We talked about this in terms of the patient, not only the patient's needs that emerge, but the caregiver's perspective and the children's needs, if there are children in the picture. So this all becomes part of the dialogue. Yes? You want to talk a little bit about that, and then I'll pipe in?
So, as I mentioned before, we need to kind of rebuild these patients who are shattered in pieces, and the patient is not an isolated entity. The patient comes with their family, with their children, with their problems, with their workplace, with us, and we need to create this family atmosphere more than a team. It's important to have a team atmosphere, make patients feel that you are with us, on our side, we are on your side, and we are on the same team fighting your disease, fighting your problems. But I think we need to make them feel that this is really family, and there is really caring about them, because they're giving you their life, you know, especially when we deal with cancer. I mean, this is like the most frightening diagnosis. It's frequently a death or life matter, and patients are not gonna just come and give you this without feeling really welcomed, comfortable, safe. And that's where all of our work really comes in, and the music has been certainly very important in creating that, and the family has been part of the music experience, and I think that I could say that's right.
Yeah, I think that to practice inclusion from the physician's role on down is key, and honesty and authenticity is introduced from the first dialogue and carried on through the role of the therapist. So patients' themes of loss, separation, isolation, anxiety, abandonment, betrayal, whatever faces these themes take with each individual, can be mirrored not just for the patient, but in the caregiver, who may be suddenly burdened with the stress of being the source of financial security. Perhaps the compromise on the marital relationship itself, that the caregiver is not the one who's ill, so often sitting with feelings that are unresolved or unmet therapeutically. And with children, there's the question of inclusion or exclusion. Are the children included in dialogues, or are they left to their own devices to form scenarios or stories that are maybe more horrific than the truth because of pulling snippets from overheard conversations or hushed conversations or playground conversations in order to organize this very threatening experience of having an ill parent? They will organize their story for themselves. And so it makes sense to give them the facts at a developmentally appropriate level. And this is the work that we do with the patients in follow-through from the initial conversation that you have.
Yeah, I would like the word about the children. It's not totally in our symposium, but it's, I think, an important issue is many times patients will ask me, do I tell my children about it? Yesterday, I had a patient He asked me the question, how old are your children? He told me they are 39, 32, and 26. And a very nice guy. So it's not like he was talking about this 10-year-old. And it's amazing that even a father who has children who are 26, 39, and 33, whatever, just felt that maybe they can't take it. So imagine the one who has a 6 and an 8 and a 10-year-old, how they're going to talk to them. And we were talking about that, John and I, the other day, and my very strong opinion is that the kids are much smarter than us. If we think we're smarter, we really didn't get it. They're smarter than us. They get it straightforward. Their mind is clear. They don't have all the baggage we have in our head. When somebody says something, we interpret it 50 different times, and then we say, maybe that's what they said. They get it straightforward. No fooling around with them. And that's how they like to be spoken to. They like the straightforward stories. And I think what they're looking for is to feel secure and to feel involved and included. And I always strongly push families to be open with their kids about it, because the kids will know when mom is sick. They will see that one day she forgot to put her wig and they found that she lost her hair. And they will see them crying, and they see them on the phone. They'll get it. And they will get the information from their imagination and their friends, who certainly they will have a couple of friends who lost their parents to cancer. And that's what will be the sort of information rather than the family. And they will know that we're lying to them. And once we lie once, they don't trust us anymore. So it's very important to find a way to be honest with them and to reassure them. Now, when they come with their parents for treatment, I always find it a beautiful experience. I always love to see. I love kids myself. I have 3 children. And I love to play with them. And we have candies, we have stuff with them. But now we have our guys from the music here, which adds to the fun. But it gives them the feeling that, mom went to the treatment, but they were not some monsters over there. They were nice people. They were fun people. They were loving people. And that completely changed the experience of these kids. I've seen the kids with Jillian the other day. Where is Jillian? Right here. I don't know who was having more fun, Jillian or the kids. I'm not sure. I had fun watching you. And that was great. The kids were so happy, and I think they go home feeling comfortable about, well, mom is getting treatment, but it's not so horrible, even if she has lost her hair.
Yeah, I think it's certainly the practice of inclusion, just to cap that from the top down, alleviates some of the pain we associate with stress and anxiety. The patient who's hospitalized or coming through treatment on an outpatient basis, the stress and anxiety of the treatment itself translates to the family relationship in a way that can be leave children and other caregivers in the family vulnerable to more stress and anxiety. So let's, I think in order to move into a conversation about music therapy and various aspects of how we work with pain, it'd be great for you to flesh out a little bit of just the trajectory. I know it's different for each person, but the impact of treatment and the trajectory of treatment.
Yeah.
Okay.
Actually, I can comment on the picture on the left. Is Bernardo here? You will comment on the picture on the right if you want?
Yeah.
All right. That lady that you see in red died actually 3 weeks after that picture. She's been my patient for more than 20 years. I took care of her first cancer 20 years ago. Luckily, I was able to cure her from it. And we had a love story, her and I. She's the most incredible woman. I absolutely loved her. And then she had another cancer, which was much worse. And within a year of the diagnosis, she eventually died. In this picture, she knew that she was on the death row. I had told her everything, which I always do with my patients. I even gave her the time that I was expecting that she will have, and turned out that was more or less right. And she was getting some treatment. And we had this wonderful intern from the program who came and played with her music. She had a good time. You can see in the picture, nobody would believe that this woman actually knew that she was going to die. She was getting chemotherapy, and then 3 weeks later, she was gone. So I think that this experience for her reminded her that she's alive. She is going to die. I think all of us are in this room. None of us is going to escape to that. But we are alive, having a good, interesting moment together here. But this woman was living the moment and continued to live. And I think the music was part of that reminder for her that, yes, she was there.
So I think when you talk about the treatment, Dr. Sara, if you could break this down into maybe phases of acceptance and coping that you see in terms of the pain experience even, okay? And the next slide will go into that a little bit. Stage of acute injury, when someone first learns of their illness, the transition period where they adapt and resume normal routines, and then the learn phase where a new baseline is formed where they are functioning perhaps at a weakened state, but functioning, and that becomes the new baseline. If you could speak to that, how you see that unfold.
Yeah, so the first state is a state of shock and disbelief. You know, you just can't believe it. You're sitting here, and frequently I'll see the patient sitting, listening to you, and then losing you. While you're talking to them, they fly somewhere else, and then you have to dance with them. You have to be patient. You have to maybe slow down the intensity of the conversation, so you know they can maybe hear you, but they frequently will not hear you and will not remember what you said the first time. So this is like a real acute shock state, and everything is hurting from the head down to the soul, to the body, to the muscles. They're sweating, all of that. And then after that first phase, we need to follow up, obviously. And we need the second session of talking, and we need all the support that we can get. And then they start to gradually digest the story, and they start gradually understand what happened. They still don't believe it. I mean, it takes a long time to really believe and digest all that. And eventually, they get to a kind of a state where they're getting it, and they're finding now a plan. They have a plan. All of us need a plan to feel comfortable in anything we do. And we need to provide them a roadmap that they feel they're comfortable on that road, and we're driving with them on that road. And that's when they start to become the savvy patients. And when we can start helping more and more after having you know, put a good Band-Aid on their wounds, which is what I call the learn phase at that point.
Sure. And I think that's where the therapist, as an individual who can bear witness in a mindful way and provide a forum for expression of those themes through actually the beginning, transition period, and into the learn phase of what does it mean to redefine oneself within the parameters of illness, and certainly within the parameters of the treatment, and any side effects that you might identify that they could experience or not. And that all becomes part of the work of the therapist in an expressive forum. Integrative treatment and family-centered care. We want to look at, you know, again, from the medical team through the therapists that are providing the support, really looking at the family. So just to digress for a minute again, what does that mean? We're going to, in getting to know the patient, share information that comes from the sessions. We share our progress notes. Dr. Sara will reflect on what he sees happening, perhaps what the patient is sharing with him in his appointments with the patient, and what's working, what's not working. And we want to look at relationships, the role of various members of the family. Are there relationships that perhaps aren't going to be resolved in a healthy way during this? Are there relationships that perhaps will be provoked by the stress of this? And where are those people in this individual's arena of care? So we want to identify healthy patterns of communication and ones that aren't so healthy. Look at healthy coping strategies from past hospitalizations or even procedures, and look at ones that aren't so effective, and help redesign, re-educate, about all three of these points, really. What's happening culturally, what are the resources of the family, and then the communication conflict. And then we start moving into music in terms of body, mind, spirit integration. And this is actually Ranit Azoulay, who ran the Breath Symposium a few years ago, and then the book came out. She's working with a patient using WINS, chronic pulmonary disease, to work with breathing. But the effects of the music on the body, this has been well covered in this symposium, so I'm not going to go into detail, but I think from as far back as Disferens in 1922, looking at the effects on pulse rate, heart rate, respiration, and the body of literature continues to grow, and inclusive of anecdotal research as well as now more and more hard medical research in terms of randomized controlled studies And we are doing our share here at Beth Israel, which I'll show you a little bit later. Music therapy, its effect on pain. This is Dr. Lowy using a gong vibration with a patient with a sickle cell. We can't talk about music therapy without referencing the gate theory in terms of when someone is experiencing pain, the experience of that allows the relay stations to remain open in a way that that person is more vulnerable to additional stress and other pain experience, deepening the perceptions of pain. So, we look at that, and that's one of the impetus for using music therapy and other creative arts modalities that provide expression. Yeah? The neurological effects of music in terms of endorphins, and that would be great to...
Yeah, I have not been here for the past day, but I'm sure many people have, discussed the issue of neurotransmitters, endorphin, which are stimulated by the music, and without going into neuroanatomy and neuroscience, but just in a layman's word, clearly the message of pain goes through some channels, and if we jam those channels with other messages, the message will be not as strong. And then clearly when we do any kind of art therapy, whether it's music or art therapy, we can see that the brain can't handle all these messages at the same time, so we kind of compete with it. And it's amazing that it does work. It does work, and there have been a lot of experiences showing that, obviously. But beside the neurological message, also there is the connection of the. You want to talk about the expression of
Sure.
later on, or
I want to cap this.
Okay,
some of the release of natural endorphins from the music experience mirrors that of opioid effects. And so, and this was pointed out in one of the other presentations, that by introducing music as a non-pharmacologic intervention, the amount of opioids can be lowered, and that's being researched as well. But we're seeing more and more patients coming into the hospital who are asking to not feel drugged up, to not feel separated or disconnected from reality. And I think we have to listen to that. It's going to happen more and more. That people coming into the hospital are now people who have done yoga or experienced therapies in one way or another, their own self-care. And so that's going to affect healthcare. And it's showing. That's why we're integrating. Yes.
But besides the fact that those drugs we use for pain are getting more and more expensive, the cost of those long-acting narcotics is just outrageous. Whenever I have a patient who has no insurance and they cannot pay for it, they call me back from the pharmacy. It's unbelievable, the price of these drugs. Besides the fact that they feel sick on these drugs. So the music is actually, for them it's free, obviously. It does cost us to pay for it, but it's much cheaper than the drugs, and zero toxicity, obviously. Besides the fact it's much nicer and pleasant.
We just actually went there and this was well covered today, so we're going to keep moving on. Again, theoretical orientation of this department is to look at the individual, cultural, spirituality, family again, and coping strategies. Current IRB research that we are doing along these lines of looking at the use of live music as opposed to recorded music, and really looking at the relationship that it unfolds between the therapist and the individual. So some of these are in completion, some of these are almost done. The spine surgery, I demoed that intervention yesterday, and what we're going to see coming up is a couple of video clips that will talk about that intervention that I did and how it's used. These are just some pain scales that we use. The color analog scale with the bodies that we use, not from an art therapy perspective, but what I found in the work with our studies is that this allows entry for the patient, the individual, to bring into tangible form the very abstract experience of pain. And just by picking colors that are subjective, blue, red, green, and yellow are the colors we offer, whatever color they want to identify the most intense pain and where, and then other colors to perhaps illustrate less pain or pain that they don't even think is connected to being in the hospital for what they're in the hospital for. So it allows this immediate portal into something tangible. And that's another entry point for the therapeutic relationship. So this is a video I want to show you. This is a case of a man, and a Chinese man, Cantonese speaking, and there's a lot of layers to this that I want to just go over with you. He was a 40-year-old man who was diagnosed with end-stage lung cancer, and lung cancer moves quite rapid. This was a very healthy, virile man, and he was admitted 2 weeks prior to his death. The work that could have happened here did not happen, but what we made an intervention that we felt was the best we could do in the time given. The family structure is that he had a 5-year-old and an 8-year-old boy. He had a 15-year-old nephew who was the only English-speaking member of this American Chinese family. And I'm going to come back to that. And then his wife. And one of the stressors that he had identified with the Asian social worker who works with us was that they did not want to tell their children, the young ones, what was going on. And I worked with the social worker and the family to first explain to the social worker why we might want to suggest or make the offering, not to push, but to make the offering, that it would create this feeling of inclusion and authenticity in their sharing of this experience. And the children would gain a sense of mastery as they move forward. So that was the work that happened that led us to this session. But here's back to the 15-year-old. You're going to see him in this video. Very intense young man. And you can imagine, in the United States, in New York City, to be the only English-speaking member of a family at the age of 15, the weight and burden that this young man feels as the voice of the family, the one to explain, unfortunately interpret some of the dialogues that were occurring, and that's really unfortunate because we have interpreter services for that. Nevertheless, you're going to see his intensity, and he was not quite on board with music therapy. The wife wanted it, the patient wanted it, and actually chose the instruments that he liked, told me he liked classical music, and was expressing that would be great for him to have for pain. And then the work with the children was also discussed in that we wanted to bring them into a non-threatening environment, that we would start a session on the day they were to come. I would work with him initially around pain. The children would come in and be allowed to participate, and with mom and dad and the therapist would simply support. And they liked that. So this happened, you're going to see that too. It's just like a little bit less than 10-minute video. I also included paper, which you're not going to see on the screen, but paper with crayons and markers, because I'm not a music therapist that is just steadfast and it has to be music therapy. I think creativity is what it's about, and so I want to be malleable all the time. And if the children cross that threshold and they want to move into something else, they have a visual form that they can go into. So I explained that through the interpreter, that they could at any time make pictures for daddy, make a sign, which also serves as a transitional object for when they leave. Then they have this beautiful poster for him that they will leave in his room. He sees it, they know they left it, and that intervention takes various forms. But the main thing was to bring them into a non-threatening family experience. And you'll see, I think the way we edited it, Bernardo, that you'll see a shift in the wife's facial affect when the children were brought in. Yes, Kate?
What was his level of pain? What was going on?
He was reporting between a 6 and a 7, but it was well managed. He was on the hospice unit at this time. But he was receptive to having music, and he found it relaxing and identified what he wanted. And it also, I think, he died the next day after this session. And I went back in to do another session, and the wife had wanted me to, and the patient was able to let me know that he wanted me. He nodded when I introduced. The nephew said no. And I said, I respect that you're here with him. I just want to check in with his wife because she had asked. And I went and checked with the wife. She said she wanted it, and the patient had said yes. So ultimately, the patient can still make that choice. I went back and did a brief session with the patient. He entrained to his breathing. And the nephew asserted after about 15 minutes, he was, that's enough. And I said, thank you. And I left. Because I wanted to honor him. They're leaving the hospital. I'm never going to be in that person's life again. And that's what's in place with that family. So I wanted to honor that and respect, show respect, while still honoring the patient's wishes and the wife's wishes. So you're going to see all this. It's a lot of stuff, but I want to play it.
I want to say one
yeah,
comment.
yes.
All right? Whether you want to hear it or not, it doesn't matter.
I want to hear it.
Okay? I observed the various music therapists we have, and I think they have all in common something that is very impressive to me, that intuition connection they have with the patients. They walk in the room, and then they just feel it. They just feel it.
Thank you.
John,
So-
that was wonderful. I want to interrupt.
Okay, I want to reflect on it, but you please go first.
I would like to ask whomever wants, but I will point to people if nobody raises his hand. One word you would say about this video. One word. What does it inspire you? One word.
Sublime. Sublime.
Sublime. Raise your voice so they hear you.
I'm sorry, moving,
Moving.
living,
Living.
Profound.
Powerful.
strength,
Strength.
powerful,
Powerful. Grace. Beauty. Anyone. Spiritual.
empowered,
In being empowered.
resolution,
Resolution. Beautiful. Anybody else?
presence,
Pleasant.
presence,
Present.
Profound.
Profound. I think we can say much more. It's extremely moving, John, and I think it's extremely powerful. And I think this really translates the fact that you can be alive till the end. This guy seems so alive.
Absolutely.
It's amazing. I've never seen this video.
Yeah.
But I was there, and this guy who was completely paralyzed, his body is gone, with his hand, he's showing us he's completely present, he's alive, he's powerful, he's participating. That's amazing. I will also add one thing that I think what get you to do that, it's not that you are a good musician, you are a good listener. And I think you were listening to this guy, and you were hearing what he was saying to you, and you were responding.
Absolutely.
That was what was going on, I think. He was not listening to you. You were dancing with him, but you were listening to him first. That's my feeling,
Absolutely.
at least.
Yeah, I think I think the video challenges some commonly misheld conceptions that music therapy at the end of life is tranquility and a harp or escorting one in one direction, when in fact the experience of music therapy all through illness, through to the end of life, can be an experience that calls one into life for one more time or two more times. And I think that that's what you're seeing, and I think it exists from the beginning of diagnosis through this point. And it's, I think what it means to be fully present for someone else as a witness, that I see you, I hear you, I'm with you, and what that means and how that speaks profoundly at a nonverbal level. The next area I want to just talk about that we will use with pain is we do quite a bit in the clinic, in the infusion suite, Dr. Sara. It's procedural support, and we've heard other people speak about this. So for the sake of time, I want to move right into the video showing you this. And I would love it if you could speak. This is Loida. If you could speak about the patient, that would be great while I prepare.
Oh, there's the next one.
It's right here. She's not on here. This is
Yeah,
this
okay.
is the video.
So Loida is a patient who's getting chemotherapy, and she is totally frightened from the chemo, which is totally normal. I don't think anyone comes liking chemotherapy. She's even more frightened by the needles. And many times you'll see patients who are much more paralyzed by the needle than all the horrible side effects of the chemotherapy. And this is their first, step into getting treated. And this patient has actually a portacat. A portacat is a little device we put under the skin, and that is connected to one of the veins of the neck, and then we put a needle into that, and we can give blood, give chemo, take blood. But sometimes the tube gets stuck somewhere, and we can't use it anymore. So we have to move around, make the patient do movement, and eventually it works. So this is a patient who already she was scared of the needle, then her port wasn't working, And Andrew is not here today, is he?
He's not in this room.
Yeah. Another one of this amazing team was there with her, and the nurse told her, raise your arms, to try to see whether she can mobilize that portacat, and to show you how our music therapists listen. Spontaneously, Andrew started to play Blackbird. See what happens.
And I'm going to take the blood from the cord. Try it that way? Okay. Or do you want me to try to take it from here?
Yeah, I don't like it.
Keep your hands above your head, please.
Both hands?
Yes, but up here, not like this. Like that.
I have a pillow on my back.
That's okay. You want to try standing up?
Why my blood is gone?
I don't know. I'll put it down. Just reaching it. Well, I didn't look at it.
makes me not scared.
Yeah. Actually, the nurse asked her to move one arm only, but I think when she heard Blackbird, she started to flap it. That's what happened. I really believe that's what happened. Yeah.
So I think also, just to comment, that the playing, the frenetic playing on the chimes is a release. It's a form of release that helps create more blood, perhaps enhance the blood flow. And something that we don't always talk about, but especially in medical work, but I think that there's a fair amount of ego support that's lent to the patient at these fragile times. And you see Andrew looking at her, and they're sharing this space that's the therapeutic space, and that's priceless.
Did you hear what she said at the end? Did anyone understand what she said? Because it was not easy to understand. She said in her broken English, music make me not scared. And she smiled while she was frightened at the beginning. It's amazing.
Yeah, Mark.
Jen, there's been a move recently towards more culture-sensitive medicine. So, from a pharmacological standpoint, that the traditional one is that Euro-Americans respond well with hypertension to beta blockers, but African Americans don't. That's one example. And so the NIH has been trying to get more grants that show sensitivity and look more carefully at differences between different races and ethnic groups. Have you found a difference with different ethnic groups? And I'm basing partly my question is based on the fact we're moving from Boston to Los Angeles. I have a much larger Asian population now, and I'm finding it easier to use more certain types of explanation. I've had a couple of true hysterical Asian patients where I simply explain to them that the mind is causing the body to act this way, and they accept it. Where I would get a fight in Boston from a Euro-American if I ever
Sure.
brought that up.
Yeah.
And I'm just wondering if you've shown us two Asian patients, just what your experience in general with music therapy is with the different cultures that you work with in New York City.
Sure, I think that the best answer I would give you would be that we start always from the place of relationship and hearing what is this person's music, and we don't go in with generalizations. With that said, in the absence of information, say the patient is not lucid, cannot speak, has no family that can identify, then we resort to 101 music therapy rules, where you go to the music of the youth, or cultural music. But we always, that's the last resort. I think it's important to get to know the patient. Chinese patients in this hospital, it's challenging because China, as a vast region, music has different meaning in various parts of China, and all the more reason to be vigilant in the offering of music therapy. What does it mean to this family at this time? The intensive care unit that Bernardo and Andrew, I think, demonstrated yesterday. But the importance of that is not just because we want to find out if music impacts people in an ICU, but because we believe, and the research shows, that the hospital is a stressful environment. Even in the video with Loida, you could hear various monitors going off. Fortunately for musicians, they all happen to be around B or B flat, so we can create, tapestries of sound that can not mask them but envelop them. So it's actually a nice way to end this whole symposium with some of the quotes I want to read for you. Just philosophy and testimonial. I think we've had a lot of research and a lot of really excellent information put out this last 2 days, and it's nice to end in this way. So I want to read you some quotes about music that I find inspiring and I think speak to in music used to bring aesthetics into an otherwise sterile and sometimes hostile environment. Mihai Csikszentmihalyi, psychologist, music which is organized auditory information, helps organize the mind that attends to it, and therefore reduces psychic entropy, or the disorder we experience when random information interferes with goals. Helen Bonney, the founder of guided imagery in music, the Bonney method. Music suggests meditative states, provides a safe, structured avenue to experience difficult memories, worked through with the aid of music. Jo Salas, wonderful music therapist who's now devoting her life to playback theater, which is a social forum that supports the community through storytelling, reenactment. Look her up if you don't know who she is. She's extraordinary. In experiencing the intricate, ordered, and beautiful patterns of music, we are attuned acoustically and spiritually to our universe. And finally, Victor Zuckerkandl, a scholar. Music moves us beyond a world of physical objects that closes in upon us. And I think perhaps this is the most poignant to what we do in hospitals, because what are we surrounded with but sterile, cold, metal, hostile objects with garish lights, noxious smells, and sounds that are far from human. So that last quote is important. And then some testimonials from people that work in the healthcare industry. Dr. Sara is going to read these.
So this is one from an advanced care coordinator in a pediatric intensive care unit. Environmental music therapy transforms and transports. It brings a sense of pause and ease to an environment fraught with unpredictability. In times of grief and loss, the music creates an atmosphere of containment to help us move through the most difficult of times with support. Environmental music reminds us to slow down, to breathe, and bear witness with mindfulness. This is a quote now from a nurse in an intensive care unit. Environmental music therapy has an incomparable ability to transform a scary and intimidating critical care unit into a safe and tranquil environment. And this is from a unit clerk. It's interesting to see that, because I can tell you in my unit, which we didn't talk about today, is the impact of the music therapy on the nurses and the doctors. When we started the program 3 years ago, I had such a resistance. You know, they thought I was some weirdo when I took over that unit, and I'm a crazy guy, you know, who likes music, and he gets all these crazy guys playing music in the room. And they were resisting it. Instead of helping patients and helping our music therapists to recruit them and enroll them into the program, they were resisting it. And I knew there was something wrong, and I actually called Joanne and John and said, listen, guys, I need you to come and explain a bit better to the nurses. So we had a session when John and John came over, and they explained to the nurses what they were doing, and they walked out and say, Dr. Sara, wow, this is amazing what they told us. They were not seeing it, it was happening, but they were completely blind. And after that, it changed completely. And now, I can tell you, I don't think that they will accept to work. Actually, as yesterday, 2 days ago, there was a man who was getting chemotherapy with his family, and he was having a session of music actually with you and then with Jillian. And one of my nurses told me, Dr. Sara, this guy walked out the first time he came for chemo. He said, never again. And then they kept him in, and he kept coming back. And I think this guy, without the music, would have stopped his chemotherapy. That was an impressive story. So that shows you how far now the nurses are feeling, well, wow, these guys are on our side. So I'll tell you, so this is a unit clerk, all right? Environmental music therapy is serene. It is easy to get lost in melody and for a moment forget about needles, illness, and pain. Now I want to say one more quote that you didn't put here.
Sure.
That I was thinking about right now where I was sitting. You know, I know all of you guys are passionate about what you do, otherwise you will not be here, obviously. And all of you and all of us know the value of music. Unfortunately, we're living in a world of money, dollars, and you have to prove for whatever you do that, you know, it saved us money, so it's worth it. It's horrible. It's horrible. And you cannot measure all these things. And that's what we are fighting with, because you have to prove that by doing this, you paid so much for the music and you saved so many days in the hospital or so many drugs and all that baloney stuff, which I can't stand. It's important, but it's frustrating because you cannot measure all these things. So that's why I was thinking about, you might know probably this quote from Einstein, that is, I think is beautiful. I'm going to try to remember to say it correctly. Not everything that is accountable, no, not everything that can be counted counts. All right? And not everything that counts is, hold on.
Can be counted.
Not everything that counts can be counted. So I think this really is about what the work you do, guys, is that, you cannot come and measure it with numbers and dollars, and we should try to destroy this picture a bit of, you can constantly need to prove by money that what you do is great. I mean, we see the result in our patients, and that's what we need at the end of the day. That's what counts, more than all the money in the world.
So thank you. Thank you.